I am a professional at sharing screen now.
All right. All right, let's get to the announcements quickly. Remember, there's free CME. Just make sure you fill that little thing out that comes in your email. Remember, if there's somebody else in your room, please let us know who it is so they can also get credit.
And turn on your video, please.
Yes, and don't be afraid to turn on your video because I think John would love to talk to people today. Thanks for those of you who have them on.
So in a couple of weeks, we have the Tuesday Echo, the long-term management surveillance. Really what this is actually going to be is more older people and opioids and how that changes, and legacy patients, and somewhat on nursing homes and long-term care.
Yep.
And then the last Echo of that series, you can see there at the end of September. We are not having an Echo next week. I'll be on an airplane, and then we are pulling in our friend Sarah Spencer from Alaska. And then Wednesday, November 2nd, this is our amazing, yay. We got Sam Quinones. I still can't believe it. The author of Dreamland and the Least of Us. So he is coming on, and I am going to put up a quick poll because we need your help. So I said, what would you like to talk about? You pick, because he does all of it. He's lived experience. He's lived in all these places. He has done investigative journalism on the ground. And he said he would talk about whatever we wanted. So please vote on what you would like to hear. We'll probably be doing this throughout until he comes on. We just would love to, I could just chat with him for hours, but we'd like to know what y'all want to hear.
Yeah, so if you have a big thought, just pop it on there. Or if you want to email us or send us a message about if you've read his books. But please, one of his requests was that he'd love it if people have actually read the book when you come on the Echo. He'd love to discuss it. Seems like really a pleasant guy. Got right back to Heather, so I think he's real interested in doing this.
And just so you know, Kurt had to serve me when I was right.
Yeah, I didn't think we'd get a response, but
all right.
Yeah. To be clear, he normally charges $10,000 to $20,000 for his little things, and he's doing this for fun. So,
all right. So, thank you for that, and we'll kind of keep with the announcements.
All right. And if you need some technical assistance, remember, reach out to Aaron or us. Our phone numbers are there. Happy to help if you need anything or have particular patient issues.
The Online Resources Center has all the information about all the different echoes, and early September, we will have the entire manual. For those of you who understand, we wrote that manual a couple times. Entire manual will be electronic, so it has all the information about every topic, and then all protocols and handouts and flyers and any kind of information you may need or want to use. It'll be there.
And the Addiction Connection podcast was just released yesterday, and it's the second part of the sugar addiction, which again is not really an addiction. But we did it anyway because Heather thinks it's so interesting.
There will be 2 more parts.
And there's going to be a couple more. So,
and for those of you who love social media, we have now a TikTok channel because why not? And it's super fun. So we talked about you this morning on our TikTok, John. Sorry. And just the general survey on echoes, please take those in email too, but there's a link there. And with that, we will turn it over to Dr. John Cole from Hennepin Healthcare. He presented a couple different times for us during the COVID echo from his perspective, one as an ER doc at Hennepin and 2 as a patient and all the above. So today we're utilizing his other lens of the opioid epidemic and toxicology and all that. So
all right,
you may take over.
Thank you all for having me. I'm very grateful to be here. Let's see, got to share screen. PowerPoint, there we go. All right, I always forget this. If I share screen with my presenter view, let's see. Do you all see my notes and everything then too? Yeah. I'll just have to do it without then. That's okay. No problem. So let's see. Yeah, there we go. Thank you all for having me. It's always a pleasure to be on. And we have, it's mostly primary care audience and addiction medicine audience, right? Some people do emergency medicine work too, but mostly primary care and addiction.
Yeah, and there, some of these rural primary care places probably do ER as primary care docs and
Right.
all that. So
Right. I remember back from my moonlighting days of being the only doctor in the hospital in rural Wisconsin, and how terrifying that is. So my hat's off to all of you who do that all the time, because that was exhausting and terrifying. But this is an interesting talk to give, because the perspective on the emergency department and the opioid epidemic is like, it's like talking about the Lord of the Rings in 30 minutes, right? Like there's just so much to unpack and spend time on. And so I ended up, when I put this together, and these are the learning objectives for the day, but managing precipitated withdrawal and talking about the risk, or maybe not risk, of environmental fentanyl exposures, and then how long to watch people after we dose them with naloxone in the emergency department. These are just 3 questions that I picked because I think they're the 3 most common things that I get asked about in the course of my work and my practice. But they don't even represent the bulk of what we really do every day. Most of what we really do every day right now is talk to people about their substance use disorder and what the next steps are going to be. But that's been a big change in the last couple of years, and in that case, we're the ones catching up to all of you. This is the area where we still get kind of these unique, special questions, and I feel like they're important, if nothing else, for when you end up talking to patients about what they're likely to encounter out in the world if they have an acute event. So let's start with the first one, with naloxone and how long to watch people afterwards, and what do we even do once the drug has worked, right? Because if naloxone's not working, it's really easy, right? That's straightforward. You keep bagging them, and eventually you have to intubate them and put them on the vent. But right, naloxone is the pure mu-opioid receptor antagonist, right? And I use this slide down here because I think this figure, because I think it's one of the best, simple descriptions of how it works. But essentially, right, like it occupies the receptor with the same or greater affinity at the mu receptor than essentially any opioid, without actually turning the receptor on. And so it really does just take the place of any available opioids there. And in the case of acute overdose, right, reduces the effects on the midbrain and allows you to wake up and start breathing again. You can give it IV, IM, intranasal. You can give it sub-Q, you can give it sublingual. You can give it nebulized, actually. There's some literature on that too, for patients who are not doing so great, but are able to at least have a few breaths come in. And that was sort of a fad for a while, but we give it lots of different ways. And it works all the time. I don't think I have a shift now where I don't take care of a patient who got reversed with naloxone. And one of the most amazing things that we see on the routine now is people who use together and have a friend reverse them, which is something that was completely new in my time. The first experience that I ever had with that actually was as a toxicology fellow. And I had a patient who was buying heroin, decided to use when they bought right there. And the person they bought the heroin from, this is back in 2010, carried naloxone with them and came with them to the emergency department and had reversed them, which I had never even heard of before. And I did not realize that person was way ahead of their time, as it turned out. But regardless of who gives them the naloxone, we often are struggling with, well, how long do we watch you now that you're breathing again on your own? How long do we keep you in the emergency department? And it turns out that some people have done some reasonably good work on how to make this decision. So this is the study that I recommend that everybody read. It's open access, and it's in academic emergency medicine. It's from upstate New York, from the University of Buffalo. And Brian Clemency is the main doctor. And he's not a toxicologist, he's an emergency doc, but has a really strong interest in opioid use disorder and the care of opioid use disorder patients in the emergency department. And then Willie Eggleston is the second author, who is a clinical toxicologist at the Upstate Regional Poison Center. And that paper, the OUR study, and we'll talk about where that name comes from in a minute, is a sort of a validation of this really novel paper, which is over 20 years old now. And this is when heroin was much more of a niche. I don't know if niche is the right word, but much more of a focused problem, and particularly out on the West Coast. So this is a study that was done, also published in Academic Emergency Medicine by Christensen et al., out of St. Paul's Hospital in, I think I have a timer set on my slides that I need to fix. So I apologize for that. By Christensen et al. From St. Paul's Hospital in Vancouver. And in the 90s, heroin was always been a problem, but particularly a big problem on the West Coast, especially in Seattle and Vancouver. And they struggled with this decision as well. Christensen in 2000 looked back at their own patients who had gotten additional doses of naloxone once they got to the emergency department, and came up with 6 clinical, I do have a timer set on here that I have to figure out. Sorry about that. I don't know how I did that. Came up with 6 parameters on how, what they thought were clinically important predictors of needing additional doses, and found that these 6 parameters together as the clinical decision rule had a sensitivity of 99% for predicting bad outcomes for opioid reversal or opioid recurrence in the emergency department. And they were all to be evaluated for the patient after 1 hour. And you can see them right there in this infographic that actually Brian and his group from Buffalo put together. But essentially what it boils down to is your mental status normal, and are your vital signs normal? And remembering that all of your vital signs are vital, right? That you actually make sure you check a temperature again, check the respiratory rate, and recheck the pulse oximeter once they've been there for an hour. And this ends up being really important clinically because I don't know about you all, but I know that when I record vital signs or write them down in a chart, I'm frequently, especially with the temperature, I yada yada whatever they did in triage, and don't always really double check to make sure that it's the same, and say, oh well, they didn't have a fever then. And then the respiratory rate too, same thing. Frequently I end up eyeballing it and saying, it's 14, but this sort of reinforces the importance of really checking the vital signs. But if you really do recheck them again and they're normal, and they also have no difficulty ambulating, the rule actually seems to hold up. The reason Clemency and his colleagues needed to repeat this, right, is all the things that you talked about with the Dreamland book, right? A lot has changed since the year 2000, right? Opioid deaths have gone up. The prevalence of the disease has changed. Naloxone has changed substantially, right? The route in which we give it is different. The dose is different in which we give it now. And of course, heroin, for the most part, isn't really heroin anymore, right? Most people who use heroin now are using fentanyl or some other fentanyl derivative. We'll talk about carfentanil in a little bit. That doesn't have the same pharmacokinetics and same properties that heroin did. So Clemency and his colleagues repeated the study, and they added another piece of data, which was fascinating. St. Paul's study originally was they took the criteria and then instituted them and validated them prospectively. But it was only single institution. And so Clemency and his colleagues modified them just a little bit, and then added this clinical gestalt question of, is this patient safe for discharge? They had, and they collected that data prospectively, and then they had abstractors who were medical students later look back in the chart for additional adverse events that happened over the next 24 hours. And then they also reviewed local medical examiner data for deaths within the next 48 hours. This is an infographic of the study. No. I think I know what happened. I think I took a couple of these slides from a recorded talk that I give, and that is why they're doing that. And I am so sorry that I did that. That is a new one for me in all the lectures that I've ever given. That ought to be interesting. But essentially what you can see here, right, is that the modified St. Paul's rule, which is the version that they validated in Buffalo, shows that in terms of your clinical gestalt at an hour, it actually holds up pretty well in terms of sensitivity and specificity. So if you're a Bayesian person and you really like seeing it all spelled out, you can see the negative predictive value, the sensitivity, and the specificity of the modified St. Paul's rule compared to the provider judgment are almost identical. So it turns out actually that if we also just sort of gut check ourselves at an hour and say, is this person awake? Are they clinically safe? That turns out to be pretty good too.
And what they found.
Oh boy. Oh, geez. I hope this isn't too bad throughout the talk. I'm going to have to double check myself at every turn. But these are the people that they missed. So when you're counseling patients or when you're working in the emergency department, these are the people to be careful of. Oral overdoses are not the same thing as if you snort, smoke, or shoot a drug, right? And it's just basic, simple pharmacokinetics, right? It takes longer to absorb all drugs from the gut than it does to breathe them in or absorb them when they immediately go into your bloodstream. And opioids in and of themselves slow the rate at which you absorb drugs, right? So when you take opioids with all of your other medications, we also see that like when people overdose on their blood pressure medication or take double doses and while they're taking opioids, the peak of their amlodipine frequently is much later if they co-ingest it with an opioid. So that's always a risk. There were, and when they missed those, the things that they missed were people who ended up getting pulmonary edema, which speaks to the importance of rechecking that respiratory rate and that pulse ox right at the time that you're about to discharge them. Because the earliest sign that someone is about to develop pulmonary edema associated with an opioid overdose is frequently the increase in the respiratory rate and not necessarily the increase in the pulse ox or the decrease in the pulse oximeter. So keeping that in mind is really important when you're making the decision about whether or not it's safe to discharge someone, or at least give them good instructions on when to come back. And then 2 ended up needing naloxone infusions later on that met the rule, and then 1 person needed CPAP. The limitations, right, in this study population, most people were given intranasal naloxone. And there's a couple different ways to think about that. The first is that's how most bystander Narcan is given these days. So it does seem to reflect real world practice. 3.1 milligrams of Narcan is a fair amount, but it's not so much that you would worry that it would mask an overdose that later manifests itself later when the Narcan wears off. So it seems reasonable for implementation in the real world. We don't have great data on the route of opioid exposure. So on the people that they missed and had complications, they did go back and get the route of the exposure. But unless there was a complication, they didn't record that a priori. So we don't know for sure that it's safer in inhaled, snorted, or injected opioid use. But in general, we think that's the case. And they didn't actually confirm the opioid exposure, which is sort of a like garbage wastebasket tox limitation that we get real picky about on reviews of articles because it's really expensive to do confirmatory testing on all these people, and it doesn't change clinical management, right? The bottom line is they woke up with naloxone. So I'm not sure it's a limitation from a scholarly standpoint, but I think it doesn't affect the real world interpretation of that. So here's one of the mental exercise things, though, that I do whenever I make that decision about discharging a patient. I use the hour criteria, but I'm careful with it. And here's one of the reasons that I do. So let's assume that you're able to wake somebody up with 0.1 milligrams of Narcan. And that actually happens more often than you'd think. It turns out that 0.4 milligrams of Narcan occupies way more than 50% of the opioid receptors in your brain when you give it intravenously. So naloxone is a really, really potent drug on a milligram per milligram basis. And let's also assume it's probably a little bit longer than 30 minutes, but in general, let's assume that the half-life of naloxone is about 30 minutes. Now, what if the apnea dose of an opioid is still there at 3 hours, right? So going through this simple exercise, and the top is time on the minutes, right? The top line is minutes there. And you can see the naloxone, right? You start with 0.1, 0.05, 0.02, 0.01, and eventually at 120 minutes, right, you're down to like a minuscule amount of naloxone that basically doesn't exist anymore. Now look at what happens, though, when you give 0.4 milligrams of naloxone. And you can see at 60 minutes, you still have 0.1 milligrams hanging out in their bloodstream. And look at what happens when you give 2 milligrams of naloxone. At 120 minutes, 2 hours later, you still have 0.1 milligrams, roughly, even after going through 4 half-lives of naloxone floating through their bloodstream. The problem with this is the bigger the naloxone dose you give up front, in theory, the longer you may have to watch them to make sure that they have gone through enough half-lives to ensure that you're not masking their overdose anymore. Because let's say this person overdosed on methadone and they could be recurring, their apnea could be recurring all the way out to 6 hours or 8 hours. If you discharge them at 2 hours with the first dose of naloxone, essentially by 2 hours, you know that there's nothing left. With a bigger dose of naloxone, though, there's still enough Narcan around that could actually be keeping them awake and alive. And so it doesn't mean that you can't discharge them. It just means that if you do, you need to give really, really clear instructions that if you start feeling sick again at all, you need to call 911 or have somebody nearby who can give you naloxone. Does that make sense? Sorry, Kurt, did I?
Yeah, no, we were just, it's very interesting on that.
Because your thought would be, oh, I'm giving them more, so that would be better, right?
Right. And it might be. The problem is we only know the half-life of what we gave them. We have no idea the half-life of what they took, right? Most of our patients don't even really know which opioid they actually took on a given day, let alone the true dose, right? I mean, they know what they bought in terms of grams from the person they purchased it from. But the amount of fentanyl versus Tylenol in those pressed M30 pills that they have, no one really knows for sure.
Right.
So we're stuck in this reverse situation where we end up having to actually make the calculations based off of what we gave them instead of what they took, which is not the way that we typically think about things. And it's just something to be careful of, especially in an era where we're giving a lot more naloxone than we used to.
You know, we ran into this situation a lot when we worked in jails last year, because a patient would come in, they would have gotten Narcan, or maybe they get it at the jail and then they get sent to the ER and then they legitimately get sent back within an hour. And it's like, come on, you know, because maybe that's a stigma thing and we could have a whole conversation about that, but it's like that revolving door. I mean, we've sent patients back to the ER 3-4 times because they're in a jail and they never got watched at all.
Yeah. So. Yeah, it's really, really tricky. And it gets even trickier when the person that you're worried about wants to leave and you don't want to let them. And I put this slide in here to show like how the limitations of evidence-based medicine are hard at baseline, but they're especially hard when you're talking about taking away somebody's civil rights for a short period of time, right? This is a huge deal. And one of the things that is really fascinating to me is that the standard of care and your ability to do that changes completely depending on which state you're in. So in Wisconsin, when I used to work there, unless you're a psychiatrist, you can't put a hold on someone to prevent them from leaving the emergency department. The police do that. So when I was working in Hudson and St. Croix Falls, and I had somebody who wanted to leave, and this is for any reason, I had to call the local cops and they had to come and make an assessment. In Minnesota, we have the 273 statute, which my slide cut off there a little bit because I wanted to include the statute. And actually, you know, the statute for holding people in Minnesota is only about 1,000 words long. It's really, really short. And any physician who's ever in this situation should read it and read it more than one time. Because first of all, it often changes every 2 years when the legislature meets. But two, it gives you a much clearer idea of what you really can and can't hold people for. And when you're doing it for this situation, it's real tricky because they are awake and of sound mind while they're making this decision. It's just that they have an antidote in their bloodstream that's keeping them in that state for the short period. And it's one of those situations that it's probably smart to talk to your hospital legal counsel about what should I actually do in this situation before running into it real time. And my thinking on this has changed about 1,000 times over the last 5 years. And I don't know what to tell you to do it perfectly every time, because there's not a right answer for this. There are people that I've held and there are people that I've let go where I've worried about it. And I've anguished over both of those decisions. But it's a good reminder that we have evidence to guide our decision making, but the implementation of that in the real world is really, really tricky. So some take-home points on the hour criteria, right? You can, and these are available online, right? Like you can go to MD Calc and find it. It's super easy. Clinical judgment versus the actual rule are pretty similar. IV and snorted overdose in an hour is probably safe. You'll have to decide in each case if it's good enough or not. But people who are low risk in an hour still get complications. And the people who do are people who have big Narcan overdose, big Narcan doses, oral overdoses, especially big ones, and then long-acting opioids like OxyContin. So does that make sense? I used to watch people for 4 hours. I watch them less now. And this is the data that I base that on, but I don't do it the same way every time. So sorry, Heather, did you have a question?
No, we were just kind of discussing questions we'll ask you at the end.
Oh, okay.
About this.
Oh, the pulmonary edema due to reversal or due to the opioid. That is a great question. And actually, maybe I should just talk about that now. So that's a really good question. And actually, I don't know the answer to that of if it's the opioid or if it's the Narcan. And I think truth in the universe is that it's probably both. So if you go back and look like in Goldfrank's, which is the standard textbook for toxicology, and you like really pull at the references, you can find a paper written by William Osler, like that Osler, describing pulmonary edema in patients who use for recreational purposes just opium, just pure, like the opium tincture. So this phenomenon where people get fluid that's third space into their lungs has existed for way before naloxone was ever synthesized. It's also true that opioid naive patients who are brought to the operating room and given opioids for general anesthesia and are rapidly reversed with Narcan do develop pulmonary edema sometimes, right? Where it's clearly temporally related to the naloxone. And it's also true in an animal lab that if you make a canine intoxicated on opioids and give them Narcan and reverse them, particularly when their PCO2 is very high and they've not been breathing very much, that their catecholamine levels go up 30-fold, and you have a huge afterload to contract against, and fluid does sort of back up into your lungs. And so, and in Osler's version of this, essentially what he described was patients with decreased respiratory depression inhaling against a lax glottis, and then creating negative pressure negative intrathoracic pressure, and then pulling fluid in by third space mechanisms that way. So in toxicology, a lot of times we argue about, is it the opioid or is it the Narcan? And I think the evidence is compelling that both are contributory to some degree. And I don't know if it's just the Narcan or not. We definitely have people who are bagged at the scene who seem to have pulmonary edema later on, even though they never got Narcan. But it sure seems like that happens way more often when people get reversed with big doses of Narcan. In the OR data, that effect seems to go away as their PCO2 gets normalized ahead of time. So it's just one more reason to teach EMS and emergency workers to bag first and then give the Narcan to try to normalize their PCO2. But that is whoever asked that question, it's a really, really good question. And the truth is we don't know for sure.
So Christine, I saw you turn your video on. I don't know if you have any follow-up. I have you're still muted, Christine.
I have a lot of follow-up. I do. I think it's so in theory, if we bagged patients prior to Narcan, we wouldn't have that, because in the field, I feel like patients get a lot more Narcan than they get, say, in the operating room or post-op or something. So they get a lot higher of a dose, and maybe they're not right away going to bag them first. They're usually Narcan first, I believe.
Yeah.
So the thought is, so no one's done that study where they do bag first, get the CO2 down, and then give Narcan. That's not something yet that we've done.
I think people have looked at that retrospectively, like in people, when you go back and PHAC retrospective data, and it does seem like it's better that way, but I don't know of a good prospective study that's evaluated that.
With that, and just with, we're talking about like at the scene, like Christine said, if it's a friend giving it or a family member giving it or some random bystander walking down the road giving it, and, especially with fentanyl, maybe you're going to get into this, people think it takes longer. And Beth Bilden's on here and she'll say, well, it really doesn't. And they don't need to give 5 doses simultaneously, but that's what people are doing. And so is that like literally, yes, you're saving your friend's life, but now you just
tipped them
way over and they're screwed,
Yeah.
basically.
Yeah.
Have there been studies showing that and maybe it's not out there yet because of fentanyl, but those quick back-to-back doses, and is that like an exponential? Is it an additive risk?
It's real tricky. I don't know the answer to that. That's all the data is observational and it's mostly retrospective and it's not high quality. I think the messaging for all of us is really important about paying attention to knowing our audience. So when it's bystanders and lay people, I don't think we should give any mixed messages that Narcan is bad. I think we should just say, this is a life-saving antidote and you should give it. Maybe don't give 5 doses, maybe give it a little time to work, but still, like, I don't think we should mix our messages there. Here's an example. On my shift yesterday in the emergency department, I had 2 patients who had terrible acute, like clear anatomic problems that needed pain medication. And both of them refused the fentanyl that I wanted to give them because that's what people are dying of on the street and I don't want that. Like, your femur's broken. It's okay to get a dose of fentanyl, and actually probably it's better for your mental health down the road if you do.
Like,
and like that's where
Michael Jackson.
Yeah, right. Propofol, and in the aftermath of Michael Jackson, right, or Joan Rivers, right. And so it's the, like, that's why public health messaging and bystander messaging is, I think it's so important for us to be just clear. This is a life-saving antidote. It's safe for you to give, especially when you immediately call 911. For EMS workers, I think it's different. And I think we can be a little bit more nuanced and say, like, look, you guys, the bag valve mask is still the ultimate tool here. And you are trained to do this.
Yep.
So
yeah.
Anyway.
So then the question that just came in is, all these different doses that you get, whether it's the free kits or, the ones on the streets you can buy from pharmacy or whatever. Now there's this new 8 milligram dose because people think you need to give a whole heck of a lot more for fentanyl. How well studied was that?
Well, I have thoughts, and they're in some slides that are coming up, so I might save on that. I still think, though, we can debate all that, and this colleague of Beth and mine's, because there's like 300 toxicologists, so we all know each other, right? Like, it's like the size of a big med school class. Like, there's just not that many of us, so you can't help but know everybody. And one of the people who was really instrumental in a lot of that stuff is a toxicologist named Lewis Nelson, who's an East Coast guy. And Lewis was on the FDA panel that made that recommendation, and I talked to him about it, and it was very controversial, and there was definitely not consensus. So I think if you have skepticism, it's well earned. At the same time, if you also are just worried that we want to cover our bases, I think that's legitimate too. I mean, there's a reason there's controversy over this particular issue. So one last thing about all these data, all these studies though, about is it okay, safe to discharge people? Just remember this, right? Death is not the only really bad outcome, right? And that's frequently what they're looking for in this, right? Anoxic brain injury is really bad. A 3-week ICU stay is really bad. Kidney failure from shock is really bad. And none of these studies ever look for that stuff. It's right. It's always just, were you dead or not at 2 days? It doesn't say were you in a persistent vegetative state. So all of these should be taken with a grain of salt, and you should be careful. God bless it. I can't believe I left these slides that way. It's just the worst. I'll remember this talk for the rest of my life. This is a good example. This is a kid who I took care of back in 2015 who overdosed on what he thought he was buying acetyl fentanyl from someone in China through, he used his parents' credit card for this actually, and ended up getting butyfentanyl instead. And so the dose was totally off, and he overdosed and got a big dose of Narcan, and got pulmonary edema so bad that it turned into diffuse alveolar hemorrhage. And this was his canister here. And yeah, he spent a week on the vent. And he would be missed in a study like this, right? He would be in the good outcome category. So just something to ponder. And then I wrote this piece for this Tox blog on how long we should watch people if you're interested in kind of a written version of all of that stuff. So anyway, so to the question, right? Do we really need the big giant doses, right? So Mark Suter is a toxicologist at UC Davis who wrote this paper, and it's a little bit old now. But it's one of the first fentanyl outbreaks, and I think it's a very reasonable approximation of what we actually see in the emergency department on a pretty regular basis. So this was a case series of 18 people who showed up over a week in Sacramento, who got opioid poisoning after a quote unquote normal dose of their hydrocodone acetaminophen that they bought, right? And this is a story we see every day in the emergency department now, but nobody documents them like this anymore because it's just part of usual care now. So there's the pharmaceutical tablet on top and the counterfeit below. You can see even 8 years ago or 6 years ago, people were really, really effective with their pill presses. In this study, they actually got pills from the patients and were able to send them off for analysis. And you can see how much each one of those pills actually had. So one of them actually did have some hydrocodone, but all of them had fentanyl in them. And they had this many micrograms of fentanyl in each of those pills, right? And yes, the bioavailability of fentanyl in oral route is not very high. But when you take 7 milligrams of fentanyl, then yeah, you absorb a lot of opioids. This is a big table of biologic data that they got from all of these patients, and they worked with the people at UCSF to get all of these concentrations, which we never get on opioid overdoses anymore. And one of the reasons I still use this paper in talks is because no one publishes data like this anymore. But the things I'll call your attention to are these fentanyl levels here. So when you look at ME cases for what a fatal level of fentanyl is, the sort of low threshold for a fatal level of fentanyl is 3 nanograms per mil, 162, right? That's an enormous fentanyl concentration, right? This therapeutic is there, and then fatal. I recently looked this up for another sad case, and they've lowered the fatal level to 3 now, but at the time I made this slide, it was 5. But you can see, right? And the typical, right, 120 is what the outer limits of Basalt is the book. And there's a new edition of it in the last year that we use for references for this. But so it's really, really high. And interestingly enough, if we look back, is this the slide? Now I'm worried I messed my slides up. Nope, it's on the next one. Right, but this is like, this paper illustrates the SOAR. We just take care of opioid poisoning. We have no idea what people take anymore. And this was more of a revelation years ago. But yeah, this is the median dose to wake these patients up was 2. Even with 7 milligrams of fentanyl as the ingested amount. And I said before, right, we usually don't know what people took. And so we end up having to make these calculations based off of the antidote instead, except in this paper we do, because we have the pills and they actually were able to quantify them. And still, most people were able to wake with 2 milligrams of naloxone. The fatal levels, right, this gets into the level, and we saw this a lot with the George Floyd case 2 years ago. But this fatal level of fentanyl can only be interpreted in the clinical context that you have, right? And if you ever needed it, right, there's an example there of a person with a fentanyl concentration that's 100 times higher than sort of the minimum fatal level, who did fine as long as they got good supportive care early on. And by the way, woke with only 2 milligrams of naloxone. So I'll talk about carfentanil here in a minute, but I personally think that we don't give, I'm in Beth's camp, not surprisingly, because I almost always agree with her, partly because she was one of my teachers. But I think we probably give too much Narcan, and probably we don't give it enough time to work, especially for intranasal Narcan. But I will say, while you're sitting there watching someone gasp, seconds feel like hours. And I forgive everybody who gives those extra doses because they're watching someone, frequently someone who they love, dying in front of them, and they have this overwhelming sense of I need to do something. And I was reminded of this starkly on my shift yesterday, because for the first time in 5 years, I had a patient have a precipitous delivery in the emergency department, and they delivered in the ambulance bay and then came in with baby out, but not placenta out, and baby's blue, and the mom is screaming. And all I can think is, I can't remember the last time I delivered a baby. And oh, by the way, now I have two patients, one of whom is bleeding and one of whom is not breathing and one of whom weighs 6 pounds. I'm a trained emergency physician who's been working for 15 years, and I was terrified in that moment. I can't imagine what lay people do in similar circumstances, right? And so it was a real reminder of like how fear can grip your brain so easily. So fortunately, OB and NICU team showed up relatively quickly, and I remembered that I can actually just bag small people. I just have to do it at a slightly different rate, but still, it was a good reminder. So the last thing I wanted to put in here was this. We don't see this as much, but I get asked about this on shift a lot, is the Elephant Tranquilizer, when carfentanil kind of rears its ugly head. So it's true. Carfentanil is a real FDA-approved drug. It's not approved for use in humans. It is approved for use in animals. And yes, it is approved as a tranquilizer. That is true. And it is, in fact, a drug that you use to tranquilize elephants. That really does happen. It is true that it's 100 times as potent as fentanyl, which means, by calculations, that it's 10,000 times as potent as morphine. All that is true. It is also true that with 1.8 milligrams of carfentanil, you can sedate a 900 kilogram elephant if the veterinary textbooks that I have looked at are accurate. It's also true that aerosolized carfentanil probably killed about 123 hostages in a Moscow theater in October of 2002, if you remember this. That's a really interesting historical event. And actually, just on my plane ride home from our vacation, I watched the movie Tenet for the first time, and they recreated that scene in the opening part of the movie, which I found fascinating, that if that has now made its way into a Christopher Nolan film. They used the opera house in Kiev instead, but essentially they recreated that scene. But it is true that did happen, and it's an interesting exercise in toxicology to go through all of that. But here's the silver lining with carfentanil. And unlike the other fentanyl analogs that are out there that are less potent but not FDA approved, and we know a lot about carfentanil because it had to go through FDA approval. So there's a fair amount of data on it. There's something called a therapeutic index of a drug, right? Where you put the LD50 ratio over the ED50 ratio, the effective dose. And the reason they use carfentanil to sedate rare, endangered large animals is that the therapeutic index for carfentanil is really, 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 really high. You can err in multiple directions, and the lethal dose for that is relatively low. So the therapeutic index for fentanyl is 300. For carfentanil, it's almost 10,000. And for reference, morphine is 70, right? Like a drug that we use a lot, especially more these days as we're moving away from Dilaudid and back into the morphine. It's also true that naloxone is really, really potent. So I aired a little bit earlier, and I always forget the decimal place on this, but it's a small amount of naloxone that occupies a lot of human opioid receptors. And it also turns out that elk that are sedated with 10 mics per kilogram of carfentanil, and this is a study from Colorado State and Fort Collins, can be reversed at a 2-to-1 naloxone ratio, and that about 1 to 2 milligrams of naloxone was enough to bring them back and revive them after they darted them in this veterinary lab. And remember, the goal is to restore their breathing, right? Not necessarily to wake them up and have an in-depth discussion about what happened. And so as long as you can restore their respiratory rate, right, that's the thing that matters. And eventually they will metabolize everything off. So I think it again speaks to, like, this is all circumstantial evidence, and it's all just, we don't really know, and we just have to play the hand we're dealt for each one of these cases. But I still think the doses that we're using are probably enough. We might be overdoing it a little bit, and bagging people is still the thing that really makes a difference in the end. So I worry about carfentanil, but not as much as maybe the media tells me that I should worry about it. And then moving on to the last part here the second learning point is the environmental poisoning for rescue. And I'll breeze through this relatively quickly, but this started back around 2016 too, where Chris Green, who is this law enforcement officer in Eastern Ohio, believed, and if you watch interviews with him, he's pretty convinced that this really did happen, that he was accidentally overdosed just through the normal encounters that he had when arresting someone who had fentanyl on them and paraphernalia. So my first question about this phenomenon is, did the symptoms in this case, and there's been subsequent cases of law enforcement officers purporting that this happened, almost always they have feelings like this, right? They describe a feeling of dying, like your body shutting down, dizziness. There's an FBI video, a training video that made the rounds a few years back, where the officers were describing a similar kind of a thing, right? And does this really fit with opioids, right? Like when people use, I mean, first of all, it doesn't pass the sniff test to me of, if they felt like they were dying, would they be using them in the first place, right? I mean, it just doesn't seem like that makes a lot of sense to me. But certainly in all the people that I've taken care of with opioid overdoses, none of them have described to me a sense of dying while they're overdosing. What they hate is the Narcan and the wake up afterwards when they're in acute withdrawal, and their catecholamine levels are sky high, but not in the part where they're slowing their breathing down. And in fact, right, they feel euphoric while that's going on, right? So Green was exposed, and he says that an hour later at the police station, which again makes no sense in terms of a pharmacokinetic standpoint, in the police station, he felt that he was suffering an overdose on the white powder, which police believed were fentanyl, and that he looked up and saw that fentanyl can enter the body simply through contact with skin, which is technically true. But again, we need to unpack that a little bit. So it is true, and this is the Moscow theater event again, that if you put enough fentanyl into the air, you can kill people. So this is a very poor, grainy screenshot from the Moscow theater incident. And just to remind everybody, this was a case where about 700 theater goers, and theater like Guthrie, not theater like AMC, were taken hostage in Moscow. And the Russian government, and specifically the KGB, responded by releasing a cloud of what we now know was a combination of carfentanil and remifentanil from people who survived, who donated their clothing to forensic investigators to see what was in the powder. And it rendered almost everybody in the theater unconscious. It turns out that they waited about 2 hours to go in and the idea was they would go in and rescue everybody who wasn't a terrorist and then bring them out. And of course, they did not do this carefully enough and ended up killing 123 of the people who were hostages, and then some of the people who took them hostage as well. But they waited 2 hours to go in, right? 2 hours, if you have become apneic, is way, way, way too long, right, to safely revive people. And so that was a huge error on the part of the KGB. And subsequently, the American Academy of Clinical Toxicology and the American College of Medical Toxicology published this position statement that's open access, and I encourage people to read it. But it includes some basic things like, at the highest airborne concentration in a manufacturing plant where people make fentanyl, right? This is like, we have OSHA regulations for when you manufacture fentanyl for medical grade pharmacy. What is safe, and how long would it take? 200 minutes, even without PPE, to get to a therapeutic level. And skin absorption is true. Like we have patches for this. It's also it requires a special matrix for this to even be absorbed. Right? This is Ionsis, which is what we use. I don't use this, but this is an FDA-approved product that uses transcutaneous fentanyl for post-op pain, right? Which is much, much faster, right? Like the Duragesic patches we use for chronic pain. Ionsis is they use for post-op pain, but you have to not only have the special gel matrix, you have to run an electric current through it to increase the absorption. So they did this calculation where if you covered the bilateral palms with fentanyl patches, right, which again have this matrix, how long would it take to receive 100 micrograms of fentanyl? 14 minutes. The notion that you would have powder on your skin and that it would make you sick just doesn't pass the sniff test on this. And last, this group in Canada did this. They only did it in abstract form, but it's fascinating. In Canada, they have these self-injection sites, and this is what they look like. This is just pictures of the PowerPoint presentation that they gave. But there's no advanced ventilatory systems, right? In a lot of cases, they're just mobile vehicles with just regular van air conditioning. And they conducted safety assessments at 5 of these sites in Canada. This is in Alberta and in British Columbia, and looked at the air quality and then the surfaces. And essentially what they found is there's no biologically active fentanyl levels on the surface or in the air. Even in enclosed spaces with poor ventilation, where there's known fentanyl to be in the air over and over and over again. And these media reports of law enforcement officers getting sick frequently are followed by stories that are not on the front page, but rather on the back page and in small print saying, well, the compound in question may not have been what we think actually was the case. So this is one from the Denver Post. 2 officers, this is in Parker actually, which is a suburb of Denver. 2 evidence department members also became sick after handling a white powder. They thought they were poisoned with fentanyl and passed out. This is another one from a website that I can't say that I frequent very often, but was forwarded to me by a person who does some teaching for law enforcement, where they show an officer getting Narcan on the body cam, and he's hyperventilating while he's sick, which again does not fit with opioid intoxication. And then here's the follow-up from that Columbus, Ohio story, where they did an analysis of the powder and found, in fact, that it was meth and not fentanyl. So I think almost certainly what's happening in all of this, right, is this is misappropriation of logic, right? This is post hoc ergo propter hoc. This is the after this, before this. This is the assuming events that are close in time are related and have a cause effect, right? That leaves fall in the autumn and that snow starts, and therefore the leaves cause the snow to fall, right? So if it's not opioid poisoning, right, well, what is this, right? And it could be anything. I mean, we don't even really know. But I think the most likely thing is it's the last one on this list, right? And I gave part of these slides actually to a talk of law enforcement chiefs. And I thought that Kevin Love would be a reasonable person to get this thought across, right? Because he's a professional athlete and someone who I don't think anyone would see as a person who's weak-minded in any way, right? To reach the level of accomplishment that you have to do to play the NBA, play in the NBA. But he developed a panic disorder after he moved to Cleveland. And I literally just took this off of ESPN.com. But it's remarkably similar to what these police officers are describing, right? And it feels as real, as he said, as a broken hand or a sprained ankle, right? If you're a Timberwolves fan, there's the famous knuckle push-ups thing that he was allegedly doing when he broke his hand, and probably he just threw a temper tantrum and broke his hand punching something. But right, this is a guy who's broken a bone and describes like a panic attack feeling just as vivid and real as a broken bone for a professional athlete. And so I think they are sick, but I think it's their brain making them sick and not actually the fentanyl. Because of that, this is my one claim to fame. I got interviewed for a Radiolab episode about this called The Good Samaritan. And the episode is really interesting, but it has implications for our patients. And what the episode ends up delving into is that Good Samaritan laws are being thwarted by felony level charges on some of these patients for endangering rescuers and police officers. And it's an interesting, I have a very small part in it, but I found it really interesting because they go and interview real people who are being potentially put in prison for years and years and years for poisoning law enforcement officers when the poisoning probably did not happen. So as silly as this might seem sometimes, of like, okay, police officers might be having panic attacks and blaming it on our patients' substance use disorders. When those acts become criminalized, it has very real implications for our patients. And then Lewis is my friend who I wrote this paper on that ended up getting featured in that article, if you want to see where that all came from. So hospital observation for wake-up patients, right? 2 milligrams of Narcan is almost certainly enough. And then until better data emerge, right, for police and rescuers, basically COVID stuff should be more than enough to protect you from any fentanyl that might be out there, right? And remember, bagging, right? That's the thing that really saves people. And then the last thing, I just wanted to put a case up about precipitated withdrawal in the ED. because we run into this a lot too. And I put this in there to say, this is a patient I took care of in triage a couple of weeks ago who came in and we have a busy triage at Hennepin, right? And there are days where it gets so busy that sometimes there's not even a place to sit down, and patients end up, unfortunately, sometimes literally sitting on the ground. But this woman managed to disrupt that degree of triage with how upset she was when she came in. And her COWS was not calculable, definitely greater than 30, screaming. And she had used Suboxone she bought on the street way too close to her last fentanyl use, and was an absolute misery. And this woman's degree of, the volume of her voice coupled with the rapidity and quantity of curse words, followed by the violent manner that she kind of tore through the emergency department waiting room. I'm certain that this woman in years past would have gotten IM medications for agitation and maybe even been intubated with how agitated she was. And I think what I found so interesting about this case was that and I put all that list of therapies down there below, is that this is sort of the kitchen sink, right? This is everything that we have. And it kind of took everything for her. But we were able to convince her a priori, I know the buprenorphine did this to you, but that's also your pathway to freedom. And more of this will make you better, and we'll sit with you while this is going on, but we can fix this. You just got to bear with us a little bit. And that, plus admittedly some IM droperidol, not to get her to just be quiet, but also to just treat her nausea and her vomiting and her diarrhea and her anxiety. We were able to get her through this after a couple of hours in the emergency department with everything on that list. And I put this up here because I don't have a way that I necessarily do it other than that I offer buprenorphine first. And then after that, it's kind of whatever a nurse can get me after that. But we do see this is now becoming part of our practice. And I do get asked a lot about this, and I don't have a good answer other than it really does work to double down on the buprenorphine and give them more.
So I'm glad you ended with that. Oh, we'll get there.
No, that's just the same case again. And then this is just a plug for the research we're doing down at Hennepin. This is the Edie innovation trial, where we are randomizing people, and this is part of a 22-site NIDA study, who get induced in the emergency department to a typical 7-day prescription of 60 milligrams per day of naloxone after we induce them, with a referral to addiction medicine, versus a one-time sub-Q injection of a product called CAM 2038, which is essentially a really short, week-long version of Sublocade. With the idea that this way patients don't have to worry about the logistics of making it to a pharmacy and filling that prescription, and worrying about that and then ending up back out using again because they can't get access to their Suboxone for whatever reason until they land in clinic. So.
Okay, so I'm really glad you ended kind of with that whole bringing up the whole Suboxone and everything you just described, because I was telling Kurt and messaging Katie, we should have you come back and discuss this whole initiation of buprenorphine in the ERs. And what does that look like after they got Narcan and precipitated themselves with withdrawal? Because that is a huge thing. And that's one of the things that we prioritize when we're talking to all these small communities we go to.
Yeah.
We probably 90% of the ERs we go to, if we can even get them to talk to us, are so anti it. And it's been a struggle. So yeah, anyway.
Yeah, I'd be happy to do that.
No, kind of a question on that precipitated withdrawal when you see them.
Yeah.
Is there a certain level where you ride it out? Because, let's say they, and we all have had patients have come in and you say, hey, have you ever tried Suboxone on the street? Yeah, it made me horribly ill, because they took it too close to their last fentanyl use. But, sometimes when you do an induction, you may tip them just a little bit.
Yeah.
And it's easier to give them clonidine and zolpidem and wait and then spread it out, as opposed to give them that extra. Do you have kind of a line where you say, let's just wait, as opposed to with the old way it's always been to just flood them?
I think it's right.
That's a really good question. I don't have a specific COWS number that I do that on. I think there's too many moving points, too many moving data points to know for sure about that. I think that if you can have a nuanced conversation with them, what they're willing to tolerate in terms of risk makes a big difference about how you proceed. Yeah. So if their cows is, kind of bumping to 16 when it was the 10, and they can talk to you about it, we can just sort of make a risk of like, look, we could do this. We could give more Suboxone. There's always a risk that you might get worse before you get better. I think that's probably not going to happen, but if it does, that's where we're at. All of it ends eventually, and even if that does happen, we have other tools that we can use. But I don't have a good way of doing that. Beth, did you have something to say? What do you think?
So I think it's interesting because you mentioned that whole thing at the beginning. Then you have these toxicology friends, and half of you say one thing and half on another on certain topics. We sat in an addiction society meeting, and half of the room said, nope, we low dose induce everyone. And the other half said, no, we high dose induce everyone. Yeah. We all had our own reasons. I think the difference, thinking about what you just said versus like what I do in a clinic with starting, I only do low dose inductions now because I don't want to precipitate, but I also don't have that whole laundry list of stuff that you have at disposal, like in that event.
In the clinic.
Right. And emergency departments aren't Hennepin. You guys are way ahead of the curve as far as doing that treatment. And
well, I think too, the presentation when they come in already in that bad a precipitated withdrawal, that's kind of, you're in that area where it's like, what have we got to lose?
Right.
Right.
Gotta throw more.
Yeah. That reminds me of one other point that I was going to make, just to state it clearly, sort of for the record, is there's a big difference between they present with acute withdrawal that got precipitated for whatever reason versus I did it to them.
Yep.
And if that's why I also tend to go a little bit low in the network studies that we do. Everyone wants us to start at 4 and then 4 and 8 and then 8 and go from there. We have always done 2, then 6, and then 4s after that. And I think one time we have precipitated opioid withdrawal in ED, maybe twice that I can think of. And I hear about most of the cases because I'm the sort of the clinical lead for this in my group. We just don't see precipitated withdrawal with doses that low. And so I think if we start with 2 and we're the ones doing it, it goes really well. The other thing is there's a huge difference if you precipitate withdrawal and the answer is to give more naloxone or more Suboxone, and you told them that was what you were going to do if this happened before you started versus, oh, by the way, this thing that made you feel crappy, we want to give you more of it right now. Trust me, this will make it better, right? It goes infinitely better when you start the conversation with, this does happen, it's rare. And by the way, if it does, the solution is to go with bigger doses of Suboxone. And that conversation goes so much smoother with the patient if you prepare them for that ahead of time.
Yeah, we tend to go to that 2-ish range as well. And in the clinic, I think, I'm using a lot more clonidine and a lot more Zofran when I send them home with it than I ever did with heroin, just because I want them to tolerate just a little bit so that we just avoid tipping them. But there's an ER study that was out a couple of years ago where they used fairly aggressive doses like we used for heroin, and they listed their precipitated withdrawal rate at like 2 or 3%. Boy, when you get one, it sure wakes you up.
Well, that's the thing. I had, for instance, I had a colleague of mine say like, oh, if this happened to me, I would just never do this again. I don't ever want to see that happen to a patient ever again. It's not worth the risk to me. And so like Beth and I in toxicology have this antidote that we can't buy anymore because it's not being manufactured, but we used for a long time and then didn't for a long time and then did, called physostigmine for anticholinergic delirium. And that's another one where if you have one case that doesn't go well and you have an adverse effect, and usually the adverse effect is a seizure, the bedside clinicians frequently just say, I don't ever want to do that again. I'm just never going to do this again. And so preparing people ahead of time, that it might happen, but also minimizing those risks is really, really important.
Yeah.
So, wow.
Other questions anyone has?
We're at 1 point.
Oh, okay. We're already past time, I guess.
That's why we come back.
I
We're
thought I
scared.
had,
Out of ways now, so no.
I thought I wouldn't have enough stuff, and then I ended up talking too long. Sorry.
No, don't. Yeah, no, this was great. And Beth has unmuted several times throughout your talk and we've ignored her. No, I'm just
No.
kidding. So Beth,
What's up?
You want to correct
No,
the record?
No, I want to thank you for a great talk. I think one of the standouts, and there are many, but one of them is that what we get to do is obtain education like you're providing and then move forward. It's hard. And the description you gave today is look at the situation, whether that's how much Narcan you give, whether that's how much, the fentanyl, whether you discharge somebody after an hour or not. That's the practice of medicine. I mean, it's so obvious, but those nuances that are picked up at the bedside, I think that's the important message to folks to say, we don't know. We do know that on post-mortem exam that patients with opioid toxicity often have wet lungs. And not all of those are in the setting of naloxone administration. But again, truth in the universe, John, using that phrase from one of our colleagues, that we don't know. But the one thing for me is that if an individual, this happened, if an individual gets 16 milligrams of Narcan in 4 minutes, I don't necessarily think they needed it. But the bottom line to the folks who administered and were on the scene is that they saved that person's life. There's no question. But a week later, to listen in a community meeting from non-healthcare to say fentanyl requires really high doses of Narcan, and this person got 16 milligrams and needed it. And the other thing, statements like somebody with no tolerance needs higher doses. I think that's another audience. And I think the message is different. And that's, again, what we get to do in terms of education. So it's the audience, it's the patient, but I appreciate all of, again, those nuances that you brought in and look at the situation.
Thank you.
I bet one of your meetings with all 300 of you in the country is
That's probably a
probably
hoot.
like speaking other languages if I was to sit in.
It gets esoteric. I'm not going to lie.
I want to be a fly on the wall.
No, we really appreciate your comments, Beth. That's very true. I think, it is. We often forget what we learn just seeing patients is probably as important as what we read sometimes. So, yeah.
Everyone wants a rule.
Yeah.
Yeah, rules are seductive, right? It's nice. It makes life easier. That's why that hour rule is so and I use it sometimes too, but not on everybody.
Yep.
You have to pick and choose.
Right.
All right. Well, we're going to have to let people go.